Good afternoon, everyone. My name is Michael McKee. I am the professor and chair of the Department of Orthopedic Surgery at the University of Arizona College of Medicine in Phoenix, Arizona. And this afternoon, I'm going to speak to you about fracture non-union and a treatment algorithm that you might find useful in your practice. I do have some disclosures in this area. I receive research and institutional support from a number of organizations, and I'm also a consultant for Bioventus and a number of other companies, as you can see here. An algorithm or assessment for patients who have non-union, in my mind, essentially comprises two factors. One are patient factors, where the quality or biology of the patient is what is critical. This includes things such as smoking, nutrition of the patient, compliance, substance abuse is a big issue, and whether they've had previous bariatric surgery, etc. Fracture factor is the second major component, where infection, stability of the fracture, soft tissue coverage, deformity, and natural history are all important. So in order to effectively use any algorithm, you have to have some facts before you start. And I would argue that these two main areas are what is critically important when you are deciding how to treat someone who has a non-union. And those are the two basic categories. This is a paper that appeared in the Journal of Orthopedic Science in 2014. And it's a fairly well done paper from Japan, looking at 102 consecutive patients who arrived at a tertiary care referral center with a non-union. They looked at these patients carefully in the manner we just described, and they found that, in their opinion, 24 of the cases were due to mechanical reasons alone, i.e. a fracture that was inadequately or poorly fixed or was very unstable. 23 cases were due solely to biological factors where everything was done fairly well surgically. Just the patient's biology was so poor, it didn't allow healing to occur. And then lastly, 55 cases had a combination of these factors. So in essence, I like this paper because I think it's probably true. Their combination of factors are important about half the cases. A quarter are due solely to biological reasons, and a quarter are due purely mechanical reasons. So it illustrates the importance of knowing what biology your patient has, because 3/4 of these cases had some kind of biological factor in play. And if you try and fix something without addressing the patient's underlying biology, that's a major issue. We talked a bit about compliance, and this is a patient that I sent home after carefully reconstructing his tibial plafond fracture, a couple of hours with small screws and plates, and gave him a long instruction about how he should be non-weight bearing, et cetera. And you can see what he's done to his cast in the 10 days or so since he left the hospital. So you have to remember that patient compliance is a major issue. And I think it's something that we overlook a lot. We believe that patients do roughly what we tell them, and I think sometimes that's the case, but a lot of the time they don't. And this is something that you need to keep in mind in dealing with non-unions, is that the reason the patient's there may be a lack of compliance. And that can be lack of compliance with weightlifting, lack of compliance with taking antibiotics, lack of compliance in going to physiotherapy, et cetera. But this is a major issue, I think, that is underlooked in a lot of our patients. Nutrition and metabolic issues are common in your patients, especially so in the non-union patient who doesn't heal. And they absolutely influence a number of different aspects of your care of the patient. They can affect your prognosis of the patient. So you can be more accurate in your prognosis in your patient's preoperative visit if you know what these issues are. They can affect your preoperative assessments. What you're looking for may not just be the wound and the range of motion and the pain at the fracture site, but it can be, hey, is this person still smoking? Their fingers yellow from cigarette smoke? Are they bone thin? Do they eat tea and toast for breakfast and lunch and dinner, and that's their main source of nutrition? And this is something we'll talk about again later in the talk. They can affect who you ask to see the patient preoperatively. So preoperative consultations are important. And this maybe someone needs to see a metabolic bone health expert or someone who needs to see a nutritionist before you operate on them. You want to optimize the playing field before you intervene to maximize your chance of success. It can affect your preoperative planning and intraoperative decision-making. If you know this is a fracture or a non-union that's going to take a long time to heal in a patient who has a number of these other issues, then you may want to go overboard in the fixation, or you may want to change your approach based on that. And of course, post-operative care is also affected by these issues, as we talked about before. If you look at a good paper that came out of the Annals of the Royal College of Surgery of England in 2016, this looked at 251 patients who had a hip fracture. And they looked at the 37 patients who had failure. And the single most important or most correlative factor with failure was not the fixation technique or what the surgeon did, it was what the intrinsic health of the patient was before or at the time of the surgery. So low serum albumin correlated with fixation failure. And I put this paper up just to demonstrate the importance of preoperative assessment. Now, what isn't clear in this particular situation is whether trying to work on someone's nutrition pre or perioperatively would make a difference. But what is clear is that the low serum albumin in this group of elderly hip fracture patients correlated strongly with fixation failure. Age of the patient, gender, the site of the injury, and the technique of the surgeon did not. So really all those things that we typically consider important were shown in this particular study not to be as important as the serum albumin or the preoperative nutritional status of the patient. This is a patient of mine who had a femoral neck fracture, and you can see there's some mild pre-existing osteoarthritis there, and the fracture is hinged off into varus. I felt that this would be one that would be worth fixing rather than replacing in this individual, so we fixed it here. And unfortunately, you can see that the patient has gone on to develop a non-union at the fracture site. What I didn't tell you was that this patient was alcoholic, was very malnourished, and lived in a bus shelter. And I think that if you look at this combination of factors, then this mechanical failure of his fixation, and arguably there's some improvements you can make there as well, probably resulted in this non-union and was predictable. And thus, in fixing this patient, who was, I think, if I remember correctly, only about 45 years old or so, we have to address both of these issues, the patient issues and the fracture issues. You could look at improved fixation with a valgus osteotomy here for the fracture, but sending him back out drinking into a bus shelter is probably doomed to failure as well. And you need to stabilize his life situation, get him off the alcohol, and get him a little bit better nourished before intervening again in this kind of situation. So that's one of the things I mean by I'm talking about the patient factors are very important. Well, what is this overweight but malnourished syndrome that we speak of? And there's a number of good articles about this in a variety of medical journals. Of course, neither you nor I read those regularly. But if you look at people who are overweight, we often assume that they're well nourished because they eat too much. But in actual fact, you may find that they are very malnourished if you look at objective criteria of nutritional status. And this is, again, a major issue in these individuals. If you add to that all of the other things that we face in terms of the difficulty with surgery in obese patients and the extra load that their fracture or non-union fixation is going to have placed upon it, then this, again, can be a setup for failure. And so just because someone is overweight, don't automatically assume that they are well nourished. We're also seeing an increasing number of patients who have undergone bariatric surgery. And this is an extremely common operation now in my hospital. And there's an entire bariatric surgery program. And it does great things. So for people who are morbidly obese, it reduces their weight significantly. Technically now, I think they've got it down pretty well to a science. The results are great. Most people lose 100, 200 pounds. Everything they have in terms of metabolic disturbances, diabetes, hypertension, et cetera, tends to improve, and the quality of life that they have is much better. The problem is for us as orthopedic surgeons that when we see one of these patients, the bariatric surgery also has significant negative effects on the calcium and vitamin D metabolism, the bone density, and overall success of our surgery. The one by Kingsburg, which is a synopsis in the American Journal of Orthopedics, really is an excellent paper that talks about what kinds of things you will face when you try and fix these patients. And it may be in the patient's best interest to have a nutritional assessment and a bone health assessment prior to undertaking any further surgical intervention if they've had previous bariatric surgery. So this is something, of course, I learned the hard way in dealing with a patient who had a previous bariatric surgery. And I frankly didn't, this is a number of years ago, had no idea that this was a major issue for bone and mineral metabolism, but it's now pretty clear that it is an issue and that this is something that we need to look at. Overall, it's better that your patient, be ideal body weight and not 200 pounds overweight when you fix them. And that's what the article by Smith speaks about. But it still has some significant implications, especially for getting a bone to heal, which is a little bit different from a total hip or total knee arthroplasty, where they're more worried about potential soft tissue complications. This is a paper by Mark Brinker from Texas. And I thought when this paper came out, it's an old paper, but I think it's worth looking over. And I thought when it came out, it was a great paper. He talks about patients who had a fracture who should heal, but didn't. So they had a minimally displaced fracture that was low energy. They had multiple fractures with at least one non-union, things that were well fixed, had adequate surgical intervention, et cetera, and it just didn't heal for some reason. And what he did was he looked at these 37 consecutive patients, and what they found was that the majority of these patients had an underlying metabolic or endocrine abnormality that was unknown at the time of their presentation to the non-union surgeon. And as you would expect, these were commonly vitamin D issues, calcium issues, hypogonadism, hypothyroidism, parathyroid issues, et cetera. And all of these things were the issues that likely led to the development of non-union. Most interestingly, 8 of these patients healed without any further surgery. So if you just identified the underlying metabolic or endocrine abnormality and addressed that, then their fracture would heal without any further surgery. And so that's a really nice thing for the patient not to have to undergo another surgery and get their non-union to heal. The corollary of that is if you operate on one of these patients without correcting the underlying abnormality, then you will find that you will be having a low success rate. So this is an important issue. I can remember around the time this paper came out, I was dealing with a patient who had a distal femoral fracture that was nailed and had a good job done. It was technically a very adequate job. They just weren't healing at all. And we did a workup of this type, and we found that they had a severe deficiency of vitamin D. And we supplemented the patient with vitamin D, and they healed their fracture without any further surgical intervention whatsoever. So that was a very useful thing for us to do. And this was, 15 years ago or so. We weren't all that clear on vitamin D issues back then. So this is a great paper if you want to read it. So where does that leave us with our algorithm, which was the point of the whole talk? Well, I think if you look at these issues on the left-hand side, then these are the issues that we need to address when dealing with someone who has a non-union. If they have metabolic deficiency, we need to correct it. If there's a local biological issue at the fracture site or at the non-union site, then some kind of adjunctive therapy there might be useful. So if we have a patient who has a significant metabolic deficiency or biologic issue, then underlying treatment of the underlying cause is, of course, the most important thing. But if you have a local biological problem, then some kind of adjunctive therapy may also be useful. If there's an instability or deformity at the fracture site, then obviously that needs surgical correction, among the other things we talked about. And then lastly, infection to treat any is a critical thing, and it's often unrecognized. If there's infection, we need to treat that with either antibiotics or surgical intervention. I thought I might show a few cases to illustrate some of these points here, starting with the scaphoid fracture. And you can see the scaphoid is a bone that gives us a lot of difficulty for a variety of reasons. It's very highly stressed in the wrist. It has relatively poor blood supply, and the whole thing is bathed in synovial fluid. So you can see that this scenario here, which was a patient of mine. So I saw this patient with the top left-hand film there and said, well, I don't think you have anything wrong. and the x-rays didn't show anything, and we put him in a splint for a while, and as he got better, we took it off, and he came back with more pain and discomfort. And you can see the middle x-ray there, and I thought, well, this doesn't look right. So we got a CT scan, and in the interim time, just to get the scan, which took a couple of about 3 weeks, I guess, back in my old practice where that was an issue. You can see that there's been significant progression to the bottom right. So the scaphoid is a bone that gives us a lot of difficulty. So I thought I'd show a few cases here. And there is some good level 1 evidence looking at the use of pulsed ultrasound and lipus in the scaphoid fractures. And you can see that if you look at this study by Mayer et al. That was published about 20 years ago now, there's a very significant decrease in the amount of time it took to heal when you used ultrasound compared to a control group. This is non-operative treatment in a cast. And 2.8 weeks in a cast might be a significant thing for some people if you look at overall return to function, return to work, etc. And this was fairly well done study. They used CT scans. We all know it's a lot of difficulty. We have a lot of difficulty defining when a scaphoid fracture is healed on plain radiographs. They use CT scans and a very standardized assessment to decide that there was healing here. So I think this is a good study that looked at this particular issue. So here's case number 1. So this is a 37-year-old male. He had a displaced scaphoid fracture, some comminution, as you'll see. He was fixed with a cannulated screw. It was a fresh fracture, so I didn't use any bone graft. And you can see these are his initial x-rays. And if you look at the displaced nature of the fracture, and especially the comminution on the radial border there, in my mind, this is usually an indication for surgical intervention. This is a patient who's going to take a long time to heal and will have a significant delayed and non-union rate. So we fixed him with the cannulated screw, as you can see here. And these are his radiographs at 6 months out. So even with the surgery, he hadn't healed convincingly, and there was still a very visible fracture line on both the radial ulnar borders of the scaphoid. However, the screw was solid. There was no deformity there. There was no evidence of any infection. He had a workup for that. This is a patient who has a stable recalcitrant non-union that just doesn't want to heal and needs some kind of improvement of the biological status. He was a young, healthy person and did have a metabolic bone workup, and there were no major issues there. He had good vitamin D and calcium levels. He wasn't unexpectedly hypothyroid. He just needed some local biology to improve at the fracture site. So what are the options in this kind of situation? We felt strongly that, especially given the level 1 evidence that ultrasound can make a difference in the scaphoid area, that application of a ultrasound device would be beneficial for him. And you can see here, 3 months later, that there's fairly gratifying healing of the fracture where really nothing much had happened at 6 months. So you could argue this might have happened anyways, and that's a valid argument. But I think if you look at the first 6 months, if I go back a slide, and really not a whole lot happening in 6 months' time, and then 3 months later, it looks like this. I think probably that this was a good thing to do for this patient and improved the healing of their fracture with a local intervention like lipus. So that was a clear indication in my mind of a delayed union in a healthy patient in a stable fracture. It was well fixed with no deformity. And I think that's the ideal indication for some kind of adjuvant therapy like a lipus. So let's contrast this to case number 2. This is a 45-year-old male orthopedic surgeon. He has a snowballing injury 6 months prior to me seeing him. He had operation by his partner at the time, but he had ongoing pain, discomfort, couldn't operate. He was a hip revision surgeon, so fairly vigorous activities that he had to do with his hand. He had well-maintained grip motion, but very poor grip strength and a lot of pain when he did things. This was his initial x-ray at the time of his treatment by his partner, and you can see that he's got some cystic degeneration at the fracture site. In my mind, just as an aside, when you see this kind of resorption at the fracture site in a scaphoid, then usually a bone graft is indicated. If you don't do that, then I think there's a fairly high rate of failure of fixation. You can also see that the proximal pole here is kind of ominously white. And if you look at both the AP and the lateral, you can see these starting to get some intracarpal deformity, a DZ pattern here. So this is a bit of a different situation. He was fixed with a screw from a volar approach. This operation was not done by myself, but no bone graft was used, which I think was probably an error in this particular situation. And then he comes to see me 6 months after that, still painful. So here's the situation now. So you can see that we have something not dissimilar to the first case, but we don't have any stability at the fracture site. We have a screw that's backing out. We have ongoing cystic degeneration, and you can see that we've got that ongoing carpal instability. So there's a significant difference here. And we have also the knowledge that no bone graft was used, so there's nothing filling that defect of resorption around the scaphoid. So is this a good case for something like lipus? And in my opinion, no, it's not, because we don't have any kind of biology at the fracture site. We have a cystic degenerative hole without any bone graft in it. We have an unstable situation. The screw's backed out and there's a minimal, if any, purchase in the proximal pole. So this patient, in my mind, doesn't need an ultrasound. This patient needs a revision operation with a bone graft and a better screw placement. And this was a number of years ago. You could argue now that perhaps a vascularized fibular graft might be indicated in this kind of setting, a proximal pole fracture, previous failed surgery, et cetera. At the time we did this, the tricortical graft was my treatment of choice, and still is, frankly, and better positioned screw. And this patient went on to heal fairly promptly with that. So I like this case because I think it clearly illustrates those last two cases, the difference between when you would use a lipus and when you wouldn't, both in healthy patients, but one had a good local situation with a well-fixed fracture, no gap at the fracture site, just needed some biological stimulation, versus the other, the second case here, where there was no good bone graft at the fracture site and we had mechanical instability here. And this person went back to doing revision hip surgery without too much difficulty long-term. So I have good soft tissue coverage. I don't have a big bony defect, certainly less than 10 millimeters. I don't have any deformity or infection. I have a stable fracture, usually with intact fixation, and there's no evidence of any progressive union. So multiple x-rays or serial x-rays don't show any improvement in the situation. So these things have to be present in my mind for this to succeed. I thought I'd show another case, and this case is courtesy of Dr. Bob Zura from Louisiana. And he had a patient, was a 69-year-old male who broke his ankle playing golf. He had a boot for 8 weeks, cast for 5 weeks, and he developed what appeared to be a non-union of his lateral malleolus, and he was advised to have surgery and eventually referred for further intervention and a second opinion. You can see there that there's a significant fracture line still visible in the lateral malleolus, and that's not uncommon. You can often see the fracture line months or years after, despite the fact the fracture is healed around it. So this is a situation before you want to intervene on someone that you'd like to make sure what you're dealing with. So this patient received a CT scan, and I think most of us would have to agree that there's a pretty clear fracture line on a number of different cuts on the CT scan here that would show that this is not a healed fracture. Now, having said that, it also looks like it's fairly well aligned. It's got decent soft tissue coverage. Infection is not a concern. The patient has never had any surgery. And it's not grossly mobile. There isn't a large pseudarthrosis there. It's just a fracture line which is persisting, and the patient has pain. So again, now the couple of options here. One would be to look at the metabolic and nutritional status of the patient. They were fairly healthy, and there were no significant issues with vitamin D or calcium or hypothyroidism in the patient. And they had a good serum albumin, so that wasn't the issue here. It was just a local lack of healing here and a relatively stable fracture line without a lot of cystic degeneration. So if you think back to the criteria I just spoke about for when you would use some kind of adjunctive therapy here, this is maybe a good indication. I have to say, if I saw this patient a number of years ago, I would probably recommend surgery, saying, if you still have pain and you can't do the things you want to do, I think this should probably be fixed. And that's definitely something that my opinion has changed on with time in order to get this to heal. So the question is treatment And lipus was used in this particular patient. And you can see 3 months later, there's pretty gratifying healing of this fraction. Again, you could argue, well, this is going to happen anyways. But I think if you look at what the situation was like at 6 months out, and then you look at what it was like with the application of lipus only 3 months later, it's pretty gratifying healing of this particular fracture for this particular patient. And there's the CT scan for those of you who are cynics out there in the audience. You can see here that we've got pretty good healing and obliteration of the fracture line in this kind of setting. Here's another case. So here's a case of a classic tea and toaster, as they would say. This is a very pleasant lady from Northern Ontario who's had a humeral shaft fracture. She's had two. This is the second operation she's had to try and get this to heal. And you can see that there's been mechanical failure, and that there's also, if you look at the fracture site intraoperatively, it's just really nothing happening there. There's no sign of any healing. It's great, very atrophic, et cetera, et cetera. And so we did a workup on her, and you can see that she has low vitamin D, low calcium, low albumin, decreased muscle mass, low sodium, low vitamin B12. I mean, she was really very, very malnourished. And so before we did anything, we wanted to try and correct as many of these issues as possible. This is a lady who had a preoperative metabolic bone health workup. She was placed on vitamin D supplementation. She saw a nutritionist. She had her nutrition improved. The calcium came up. She had a bit of an exercise program, an aquafit program. Now, she couldn't do too much, obviously, with her arm flopping around like that, but she became more active. And a number of these other issues were all correctable before we did anything. So before we tried to get this to heal, we had all of these metabolic issues corrected. Now, so if we look at her fracture here, I think it would be safe to say that this lady needs another operation. She has gross mechanical instability. She does not have good alignment. This is not something which is going to heal with simple adjuvant therapy. She's going to need some basic mechanics improved, and that's what we did with her. We used a long plate, and you can see there's a cortical strut graft immediately there. We also added a BMP compound to the fracture site to get this to heal. So this is not someone who's going to heal with lipus. This is someone who needs a major reconstructive operation, and there's a plate, a cortical strut, and then the BMP, and an optimized, medically optimized patient, and she had pretty gratifying union fairly quickly. So that's a situation where intervention of some kind is going to be required. So this is another similar situation. This is an 8-year-old female who's had 2 prior ORs, both of which have failed. She has some medical comorbidities which are being fairly well treated. And this is someone who's had, and if you look carefully there, you can see a number of screws from 2 separate previous operations, not just one. So with the ESR and CRP and 2 failed operations, infection was a significant concern in this patient. And so one thing I will say is that when I'm doing an operation of this type, both this patient and the previous patient, I have it in the back of my mind when I'm doing the operation, regardless of the preoperative workup, is that this is probably a patient who has some underlying, at least contamination, if not frank infection. So even though the workup may not be clear or conclusive, I'm going to do this operation as if there is infection there. So what that means is all of the pre-existing hardware comes out, all of the tissue that's dead or devitalized or of questionable viability comes out. And when I'm done, I'm going to wash with at least 3 or 6 liters of normal saline. I use gravity feed, just saline, no additives, wash it out. Then I'm going to refix it. And then usually now I put some local antibiotic powder in on the way out in terms of trying to minimize the risk of recurrence. And I would say that probably about 1 time in 3 where a patient like this doesn't really have any preoperative evidence of infection, we either find something intraoperatively or the cultures that I take at the time of the surgery end up growing something. So that's an important point for this kind of patients. And this is where sometimes you have to expect the unexpected. For one thing, in this particular patient, we wanted to optimize the nutritional status, and we did do that with the medical and nutritional consult preoperatively. We want to improve the fixation, change from a plate, and that's the old DCS plate that was in vogue for a while for fixing subtrochanteric fractures, change to an IM nail type device. And we also wanted to recognize that if this does come back with a positive culture, we've done everything we can intraoperatively to minimize the risk of infection in this kind of setting. And this is that patient down the road with fairly gratifying healing with all those things corrected, nutritional status corrected, the device fixed with a better device, and then thorough irrigation breed one. And she did actually grow some scant growth of staph epidermis on a couple of cultures post-operatively, even though there was no obvious sign of infection at the time of the surgery. Well, any talk on non-union in 2020 wouldn't be complete without a little bit about smoking. I mentioned before I was going to return to that and talk about it a little bit. And I think so many times we see fractures that should heal that don't because of patients' heavy smoking. And this is something which is becoming very, very well recognized. We wrote a paper back a number of years ago, and I used to do a fair number of circular frame reconstructions. There was another colleague of mine in Toronto, Dr. Dave Stephen, who did the same, and he and I decided to look up in a series of our patients, all of whom had a lower extremity Lizaroff placed on, typically for a tibial non-union, infected tibial non-union. And our impression was that smoking was a really negative prognostic factor in this kind of setting. And we thought that we'd look at our patients and see if this was in fact the case. And we had 84 patients with an Lizaroff frame on their lower extremity. And we found that the poor results, and there's a number of criteria that you can use to find that, what happened to 38% of people who smoked, only 8% of people were non-smokers. And this was a highly statistically significant and clinically relevant difference. So a huge failure rate in smokers compared to non-smokers. And this, unfortunately, many patients who smoke end up in the situation where they're going to require an Lizaroff frame because that's what gets them there in the first place. We had 5 amputations in this series, and all of them were in smokers. So this was pretty powerful evidence to us that smoking had a negative effect on this procedure, which was really a last-ditch procedure to save limbs in a lot of these individuals. Well, so what? Does it make a difference if you stop smoking? Well, apparently it does, and there's some pretty good evidence, level 1 evidence. This was in the JBGS about a decade ago, and I think this paper was actually from Scandinavia somewhere, if I remember correctly. And they looked at the effect of smoking cessation on the complications of acute fracture surgery. It was a randomized controlled trial, and the complication rate decreased from 38% to 20%. So basically cut it in half with an intervention to get people to stop smoking after they had acute fracture surgery. So there's pretty good evidence in the literature, and this would correlate with my own personal clinical experience, that if you can get a patient to stop smoking, it's never too late to quit, never too late to quit. Then you can decrease the rate of having acute complications. And, sometimes I joke with patients and say, I want you to stop smoking just for 6 weeks or so until we get their fracture to heal. Once we get your fracture healed, you can smoke twice as much to make up for it. I don't really care, but just give us that 6 weeks. And they often find that quite funny, but it is true. And if you can get them to stop smoking, then usually that's very beneficial for fracture healing. And I'm going to end with one very important point, and that's know your limitations. And I think that was a line in a famous movie once where they said a man or woman has got to know his or her limitations. All non-unions are not amenable to healing. Simply getting the fracture to heal on an x-ray is not winning the battle if it takes forever to get there and the patient's out of commission for ages, et cetera, et cetera. Know when to bail out to an arthroplasty or an amputation, and keep sight of the forest, which is your patient, and not only the trees, which is the non-union you're dealing with. Last case I'll show is this, the patient who had this, I think was her second go at having this fixed. She's got a distal humeral non-union. She has very small intra-articular fragments. She has a failed fixation. There was some question of lingering infection after her first operation. And this is a patient who was basically living independently and doing quite well before all this started, and now it's been reduced to living in a nursing home and an assisted facility because she can't look after herself. You can see by the look on her face, she's not too happy with her arm on the clinical picture there. And if you look at this patient, and she was relatively unwell, she had a lot of medical comorbidities. She'd been going on for like a year or more like this. and really had a significant decline in their independence and overall quality of life. Is it possible to get this to heal? Well, maybe, you know, if you had 3 or 4 plates and you put an ultrasound on immediately post-operatively and you bone grafted it and you put it on a splint for a long time, et cetera. But I'm not sure that that would be beneficial for this patient. She wanted something done quickly and promptly and move on. And in my own hands, this is a good setting for an elbow arthroplasty, which is what she received. And you can see these are the issues that we dealt with her: inadequate fixation, heavy. She was a heavy smoker at the time, and et cetera, et cetera. So she received an elbow arthroplasty and was able to get moving this right away. And that's what I mean when you say know your limitations. And this did her quite well for a number of years afterwards. So to conclude, I'll say metabolic and nutritional conditions are surprisingly common in your fracture and non-union population. And it's very much in your best interest to know and recognize these problems and intervene to help these patients. And if you go back to the first slide I showed in that first talk, about half the time these fracture and patient factors combine to produce non-union. A quarter of the time it's just fracture factors alone or inadequate surgery, and a quarter of the time it's metabolic issues alone. So 3/4 of the time your non-union is probably at least being contributed to partly by some kind of metabolic nutritional condition or smoking. You need to know how to recognize these problems and intervene and help these patients. And by that, I mean, you want to optimize their nutritional and metabolic status before you operate to maximize the chances of success. Bariatric surgery is an issue. Smoking is an issue. The female athlete triad, and I didn't go into that too much today, but the female athlete triad, especially with stress fractures in the lower extremities, is a major issue in getting those fractures healed. And you can read a bit more about that. And there's a number of treatment issues there. And the elderly with comorbidities are all subgroups at risk for this. Carefully planned surgery in a patient with optimized metabolism and biology is what's going to equal success in your practice. So I'll stop there. I'd like to thank you very much for your attention. And one of the nice things about this format is that we're happy to take questions, and I'm sure there'll be some issues that I can clarify or answer for you. And so we will go from there. Thank you very much. Hello, everyone, and thank you very much for attending today's webinar. My name is Michael McKee, and you've just watched a session that I gave on how to deal with patients who have difficult fractures, who develop non-unions, and the various investigations and treatments available for those patients. So now we're able to go through a question and answer session. A number of questions have come up during the talk that I'm going to be happy to answer for you. I would again state, if you have questions, please put them in the chat room and we will do our best to get to them during this next 20 minutes or so. The first question is, if you discover a metabolic or endocrine underlying issue, do you treat the fracture with lipase as well as the treatment for the underlying deficiency? So that's an excellent question. First things first is, if you do define a underlying metabolic or endocrine abnormality in your patient, then I think probably the most important thing is to deal with that issue. And that may involve, or probably will involve, consultation with a medical specialist or with an endocrinologist dealing specifically with that issue. And that is probably the most important thing to do, number one. After that, what I would suggest is that it depends on the fracture you're dealing with and the other situations we talked about in the previous session. If you have a fracture which is well aligned and has fairly good soft tissue coverage, and it's not infected, there's no significant deformity, then if you correct the metabolic abnormality and add lipase, then I do think that's possible to get that fracture healed without any further surgical intervention. If you have a patient that's going to need another operation, but you still have a high risk, in your opinion, based on literature and your experience, for delayed or non-union, then I think lipase is a major benefit in that kind of setting. And you remember, if we spoke about the paper from Mark Brinker's group, is that of the 30 patients or so that they found, they had a significant number heal without any further surgical intervention. A lot of the time that's from dealing with the underlying metabolic or endocrine abnormality. And in my opinion, that can be augmented with the use of lipase in the appropriate setting. Again, no deformity, good stability, no infection, and reasonable soft tissue coverage. So I do think that adjunctive ultrasound therapy can be very useful in that kind of setting. The second question that I'll use is, what is your usual preoperative workup for metabolic disorders? So this is a good question, and I'd like to stress that I don't consider myself a metabolic expert, but what we do like to do is screen for things that are something that can be treated by an internal medicine specialist. And often it involves just having an idea that something's not right with this particular patient. It's a fracture that should heal, that didn't. It's a fracture that seems to be taking way more time to develop callus than it usually would or could. And there's no other easily identifiable fracture or feature of the fracture that would explain this. So in that setting, we have a number of options. One is to try and investigate it or screen for it yourself. And often that's worthwhile at least starting with a good series of calcium labs and a serum albumin. And if you want to find out other things, you can look into more detail, obviously a serum glucose, maybe a thyroid study, depending on your patient. But my main role in that setting is to screen for the obvious issues that might be involved. And if I do have a positive result, then I work closely with a metabolic bone physician who I then refer the patient to. So my role there in the preoperative area is to look for patients who don't seem to be healing the way they should and have a high index of suspicion for an underlying metabolic disorder. There's some simple screening tests you can do, and the ones that typically are most useful are calcium metabolism, serum albumin, thyroid, and of course glucose, which is pretty much routine anyways. And if there are significant abnormalities there, then referral to someone that you work closely with and you have a good working relationship with and can give you some practical advice and treatment for your patient is what I would typically recommend. The next question is, are DMARDs or disease-modifying drugs such as methotrexate and or TNF and other biologics risk factors for non-union? And should they be held in patients with a fracture, and if so, for how long? So this is an excellent question as well. And unfortunately, I don't think the definitive study on this issue has been done. The main risk for most of those biologic agents, in our opinion, is the risk of increased infection. So most of those agents, what they're doing is that they're stopping white cells from attacking the native tissue. And that's a very simplistic way of looking at it, but they're designed to prevent autoimmune disorders and white cells from attacking the body's own tissue. If you have those agents on board, then the main concern is that they also affect, of course, white cell function to resist exogenous infections. And if you look at most of those ads, and many of these drugs now are heavily marketed in direct consumer ads on TV, you always hear the background voice, the fine print saying, you know, if you've had previous tuberculosis, if you live in certain areas where fungal infections are common, if you get a fever, tell your doctor right away. There are a lot of warnings about the risk of infections in this area. And so that is something which you need to remember. And that's my main concern when using these agents. Interestingly, about 3 weeks ago, we had a patient with a septic olecranon bursa and really no clear reason to have that. And she had psoriatic arthritis and was on a DMARD. And her cultures from when we took her bursa out actually grew an atypical mycobacteria. And that's definitely one of the risk factors with those agents is unusual infections or increased infection rate. So long story short, in general, I don't think they contribute to non-union in of itself, but they can contribute to an increased risk of infection, especially with surgical intervention. And so I usually ask my patients to stop those drugs for one cycle before my surgical intervention, if possible. If you're dealing with an acute fracture, now obviously that may not be possible, but if you're dealing with any kind of elective situation or you have the ability to time things, then I usually ask them to stop those agents for one cycle before my operation. Is there good science to support that? Not really, but I do think that most people would have some kind of protocol for dealing with those issues by stopping the medication during the perioperative period at least. Once the wound is healed and things look normal and there's no sign of infection, I think it's probably reasonable to start them up again. The next question is, do you send a patient to a dentist to make sure they have no dental infection before doing surgery? So in general, for me, the answer to that would be no, unless I'm doing some type of arthroplasty. And for arthroplasty patients, again, this is a highly controversial topic, but most of us have seen patients with arthroplasties who have developed an infection temporally with some kind of dental abscess or dental condition or procedure. So in general, if the patient's dentition is very poor, and I'm doing or contemplating an arthroplasty or some extensive non-union reconstruction that may include allograft, for example, which we know is prone to infection, then I would ask for the patient to have those dental issues dealt with first before having anything done surgically by myself. For routine situations and for most fractures, when you don't have the luxury of delaying things, I would not typically worry too much about that. The next question that comes up is, what is your usual preoperative workup for infection? So in general, I've always looked for a single test that will tell us whether the patient's infected or not, as a way of defining definitively what we're going to find at the time of surgery. And unfortunately, that single test still remains elusive. And I think if you look at the literature, probably the best approach is to use a combination of different tests to help you decide what the risk of infection is, recognizing it's never going to be 100% or 0%. And those tests for me typically include a white blood cell count, a complete blood count, a white cell count, a CRP, and an ESR. And that would be the standard regimen for pretty well anyone that's coming to my practice for surgery where I'm concerned there may be some underlying infection. I've relied less and less now on nuclear scan tests and white cell labeled tests because I think the evidence that they add significantly to those other three tests is not there. They become increasingly cumbersome to get. In other situations, I may also get an aspirate of the fracture or non-union site, and that may be beneficial, especially if there's a swelling or a fluid collection there. And that's a very specific test. So if you get a positive result, that helps you quite a bit. Unfortunately, a negative result may not be as useful because it's not very sensitive most of the time. Lastly is intraoperatively, we're looking again at using high-powered fields and white cells per high-powered field in the trauma setting. These tests have been very useful in lower extremity arthroplasty. They're debatable in upper extremity arthroplasty, and they have been looked at in the past for non-union. So you are fixing a non-union and you find a little bit of murky fluid there. It's not frankly infected, but it's hard to tell. Is there any use in using high-powered fields in that setting? Well, the most recent and interesting paper I saw about that came from the Bone and Joint Journal. I think the paper was from Britain. And what they found was that if there's 0 cells, white cells per high-powered field, that's usually a pretty sensitive indicator that there's no infection there. If there's more than 5 white cells per high-powered field, that's a pretty specific sign that there is infection there. So if you have one of the two extremes, no cells per high-powered field or more than 5, I think the number was 5, then those are pretty useful findings. The problem is that for the most patients who are between 0 and 5, it wasn't really that sensitive or specific as it has been in the total joint literature. So I do think high-powered field examination of tissue at the non-union site might be useful in this setting. And if you get a 0 or a +5, i.e. one of the extremes, that's probably going to tell you whether you have or have not infection. But if you have something in the middle, then that's not all that useful. The next question is, how has your process or algorithm changed in this era of COVID-19? Well, I could probably talk all afternoon about how COVID-19 has changed practices here. A few things that are very interesting in general in orthopedics in COVID-19. And number one is that most orthopedic surgeons who seem to have gotten COVID-19 or have gotten infected have not gotten it in the operating room. It seems to be something that occurs in the ER or on the wards or in other settings, but not so much in the operating room, especially if you avoid the room during the intubation process when most of the virus is around. So just as an aside, maybe not related to the question, if you want to avoid getting COVID, the OR is probably a pretty safe place to be, especially if you avoid the intubation and extubation processes. COVID-19 has made all of these things I've talked about, getting a consultation with a metabolic physician, seeing the patient in the clinic, et cetera, much more difficult logistically. So, the last thing we want to do is bring a malnourished, sick, diabetic patient with a non-union to the clinic when we know they have risk factors for catching COVID. And so a lot of those patients, especially if they're expected to stay overnight or acquire a hospital bed for a while, are actually prevented from having surgery at my institution until just recently because of our concern about them and the bed space we had a major issue with. So it definitely has made logistically looking after those patients much more difficult. At the present time, as we do get back to some semblance of normal and we do see those more sickly patients coming back to the hospital, we do, in addition to all the other tests, we also do 2 COVID tests and make sure they're both negative before we proceed. I don't want to operate on a patient who has active COVID disease. It's bad for the patient, and it's bad for the staff, and it's bad for the other patients in the hospital. So I would say the one proviso here, especially when you're dealing with, potentially elective work like a non-union, is that we'd like to avoid bringing the patient to the hospital and avoid especially having a COVID positive patient come into the hospital. In that setting, then, where surgical intervention is associated with greater risks than normal on a variety of different levels, lipase application may be something that you want to consider more so than in the past. And there's never an absolute indication for or against something, but it's always a balance of probabilities. So if the more conventional treatment for non-union, which might be operative intervention, doesn't look as favorable in this kind of environment, then lipase is something that you might want to consider. The last thing I'll say about COVID is just in the most recent JBJS, which came out, there are a number of articles, I think one from Italy or Spain and one from New York, talking about what happened to hip fracture patients who had active COVID disease when they had their hip fracture. And interestingly and ominously, there's a very high mortality rate in those patients. So when we say we don't want to operate on patients with active COVID disease unless absolutely necessary, there's actually some pretty good evidence in the literature that if you look at a standard operation, we do like hip fracture fixation with a mortality rate in-house that's usually 5% or less. That was dramatically higher in the COVID patients. And so that reinforces our decision not to operate in that setting if it's elective or it can be avoided in any way, shape, or form. Next question is, most of these patients require pre-op examination and lab testings by primary doctor before surgery. Will this help to identify the problems you were talking about? I think that a lot of the time I'm looking for a clearance from a family doctor for a patient because they know the patient typically better than I do. Often they've known them for years and there's a good rapport with the patient. And the family doctor can often be a very useful resource in telling you whether there's an opportune time to operate on this patient. I've booked patients for surgery and the family doctors call me and said, hey, I don't think it's a good time for Mr. Smith to have a surgery because of these issues, or his drinking has dramatically increased recently and I didn't know that, or something of that nature. So I do think having a family physician who knows your patient well is extremely important and a good resource in this kind of setting. The family doctor can often identify subtle things that you don't know about, and that's where some of the lab testings by a primary physician can be very useful. So I think never hesitate to pick up when you're trying to decide what to do with a difficult problem and a difficult patient. I never hesitate to pick up the phone and call a family doctor. And I think that's something I've been thankful for on many occasions. Next question is, any utility with the procalcitonin level? I don't have a lot of experience with procalcitonin personally. I know there's some literature on the topic where it may be useful as a general measure of patients' bone health. I have fortunately, I work very closely with a metabolic bone person, and that would be something I would leave to his realm as whether that can be a useful preoperative test for the patients or not. So I'm afraid I can't really speak to that too clearly. The thing I would also like to stress in this setting is that the COVID environment has made literally everything more difficult. And we've seen a number of patients who have had their non-union or their fracture, I'm not going to say neglected, but just haven't been able to get to good medical care for a variety of logistical reasons, and who come in later than anticipated. And in general, they do well, but that's not always the case. And it may be that in some of these settings, the use of a lipus for patients who have delayed union, who you really want to avoid bringing through the medical environment right now, can be very useful in that kind of setting. So in the absence of any further questions, I think we can probably bring this to a close. I'd like to remind the audience that there's a break at 4:45 Eastern time. Pardon me, there's a break, and then we'll restart at 4:45 Eastern time for the last session. And that we truly appreciate you attending the webinars today. And we sincerely hope that you were able to get some useful information from these webinars for the care of the difficult patients that you have in your practice. So thank you very much for your attention, and bye-bye.